Good afternoon, everybody. My name is Maheedhar Gedela. I am a second-year general cardiology fellow at the University of South Dakota. So going into a different valve intervention. So I'm going to present a complex MitraClip intervention in a patient who had partial congenital AV canal defect repair, and then followed by amp-lazar septal occluder repair. And she also had severe mitral regurgitation, which was operated on before and with a residual mitral valve cleft. So these are our operator interventional cardiology team. Moving forward to the case presentation, she is a 76-year-old female who presented with progressive dyspnea and exertion and fatigue of 6 months duration, NYHA class 3 symptoms. And 6 months ago, her transthoracic echocardiogram showing EF 50 to 55% and severe mitral regurgitation. Pertinent surgical history, she had mitral valve repair for congenital mitral regurgitation and an atrial septal defect closure with pericardial patch in 1994 due to partial AV canal defect, which is followed by a amp-lazar septal occluder in 2007 due to the shunting through the pericardial patch. These were done the 1994 intervention, I'm not sure where it was done, but in 2007, it was done in one of our hospitals in our city. Other pertinent past medical history was persistent atrial fibrillation on long-term warfarin, sick sinus syndrome, post-permanent pacemaker placement, hypertension, hyperlipidemia. She had a coronary angiogram a year ago, which showed patent coronary arteries. The initial transesophageal echocardiogram, 4-chamber view, 0 degrees, showing severe mitral regurgitation. In the right side of the corner, you may see the amp-lazar septal occluder in the septal area. And this is the still frame showing mitral regurgitation radius of 1.4 centimeters. These are the other valve regurgitation parameters, ERO 0.47, regurgitant volume 94, consistent with the severe mitral regurgitation. And her mitral valve diastolic mean gradient was 2 millimeters Hg. These are some other views to delineate the mitral regurgitation pathology. Central jet, this is the 2-chamber 60 degrees, mitral commissure 60 degrees, and then 2-chamber 90 degrees, showing severe mitral regurgitation centrally directed. And mid-esophageal long axis view 140, showing severe mitral regurgitation, and AV short axis showing amp-lazar septal occluder device. And this is her 3D mitral valve, which is showing A2 cleft. Her valve anatomy was a little bit distorted with prior mitral regurgitation surgery. So the patient was referred for redo bypass surgery. After the heart team assessment, the patient was deemed like high-risk surgical candidate with her complex anatomy. So we decided to do a MitraClip procedure after discussion. So the anticipated challenges were we need to perform the transseptal puncture in the inferior-posterior part. Usually in the regular MitraClip intervention, the transseptal puncture is superior-posterior, but it may change if the valve is degenerative pathology. And because of the pericardial patch repair, so we decided to go with inferior-posterior puncture. And then the MitraClip position will be challenging due to the cleft, the A2 cleft. So we thought, okay, let's go with one clip strategy first, and if she needed second clip, we will implant a second clip. The transseptal puncture measurement from the 10th area to the mitral annular area, showing 4 to 5 centimeters, which is acceptable in the 4-chamber 0 degrees view. And this is the bicaval view showing the puncture is in the inferior. It's very fast moving. I don't have the short axis to show the posterior puncture for the septum. And this is the fluoroscopy. As you may see, the amp-lazar septal occluder and the MitraClip steerable guide catheter, and then the stiff amp-lazar wire is in the left upper pulmonary vein. And the first MitraClip was implanted at A1P1 scallop, and then the patient still has a pretty significant opening. Here we step back and then look into what the plan would be. So we decided that she needs to have another clip. So we checked the mitral valve mean gradient for mmHg, which is acceptable, less than 5 to 6 mmHg. So we then proceeded with the second MitraClip implantation at A3 and P2 scallop. As you may see, the mitral regurgitation severity decreased significantly, mild mitral regurgitation per the color flow imaging here. And this is the 3D imaging showing the almost equally spaced the three orifices and very mild mitral regurgitation. And post-procedure, her mean gradient was 5 mmHg, which is acceptable. And there was small residual left to right shunt post-procedure. We did not close this. We thought it will close eventually given the small shunt. And the clinical course, there was no pericardial effusion post-procedure and no vascular access site complications. And the patient was discharged on the next day. And the patient did well at 1 month follow-up visit with improvement of her symptoms. And we did check a transthoracic echocardiogram. At the time, her gradient across the mitral valve is still acceptable, 6 mmHg. So the discussion, the Everest-2 trial has exclusion criteria in terms of prior mitral valve surgery or valvuloplasty, and significant cleft A2 or P2, and history of atrial septal defect, whether it was repaired or not, which are the contraindications for MitraClip intervention. However, but our patient, the only option with her life-limiting symptoms were MitraClip, so the MitraClip ×2 resulted in excellent procedural success and clinical result. That's about my case. I would be happy to take any questions.
Did you purposely try to go to A1P1 first, or was that just how it happened?
So it was basically how it happened. So we thought we would achieve optimal result. We can grab even the cleft area, but it did not plan as it was supposed to be. So then, given that significant opening, we decided, okay, she needs to have another clip. So we proceeded with second clip.
Normally we do use that 2-clip strategy. We put one to bring things closer together, and then put a second clip to basically make the MR much better.
Sure. Yeah. Thank you very much.